So tonight's presentation, the first hybrid radiation and MRI machine will soon be treating patients using cutting-edge technology right here in Calgary. The Tom Baker Cancer Centre's radiation medicine program is thrilled to see the MR-Linac program at the new Calgary Centre set to be a reality very soon. Under the leadership of Dr. Lee and the team there, clinical and research teams have been working on site design, technology selection, and clinical trial designs for the program. The Calgary Cancer Centre will be the first centre in Canada and amongst a few elite cancer institutions in the world with 2 MR Linacs. The integrated system combines MRI with a linear accelerator to guide radiotherapy in real time. This technology enables precise radiation delivery to cancerous tumors while preserving nearby healthy tissues. Dr. Lee is a clinical assistant professor with the Department of Oncology, Division of Radiation Oncology. He specializes in the management of gastrointestinal and breast malignancies, and his research includes MRI-guided radiation therapy, deep learning, and cardiac SABR. Dr. Quon has recently co-authored a publication titled The Impact of MRI on Management Decisions in Prostate Cancer Brachytherapy. Dr. Quon is a radiation oncologist and clinical associate professor at the Tom Baker Cancer Centre and the University of Calgary. His recent work has focused on real-world data to improve the treatment and active surveillance of patients with low-risk prostate cancer. So we are very honored to have these 2 distinguished doctors with us tonight.
All right, thank you very much for that introduction, and thanks for the invitation to speak today. I'll start us off here. I'll give some background about just the kind of radiation planning process, and then Dr. Lee will take over and talk more specifically about the MR-Linac and MR-guided radiotherapy. So the reason we're kind of tag teaming this talk today, I'm involved more with the prostate radiotherapy side of things, but Dr. Lee has a lot of expertise and experience in the MR-guided treatment of cancers, and so hopefully we'll be able to give you some a flavor for the upcoming new installation of the MR-Linac and the kind of potential that it holds for treatment in the future here. So one of our main objectives here today is really just to describe the importance of imaging to radiotherapy planning and delivery. So while that might seem pretty, obvious that the imaging is important to treatment, really we need to talk in a little bit more detail about how it's used in radiotherapy planning and delivery. So there's 2 main aspects in the radiotherapy treatment for patients. The first part is the simulation, and so currently this is being done with CT. So you may have heard of a CT simulation or a CT planning study. That's the first step in the radiation treatment planning process. So that will generate a CT scan for us, and that's what we as radiation oncologists would use to identify the area to be treated and the important organs nearby to avoid. And then after the radiation plan is developed, then the treatment is done on a linear accelerator, and so that's on the delivery side. And both of them do require some imaging, and the upcoming MR linear accelerator or MR-Linac is really a new development on the delivery side. And we'll go into that in a little bit more detail as well. In terms of the simulation and planning, this is just a screen capture of a recent patient of mine. So this is what a typical CT simulation scan might look like, and our job is to first of all, we're contouring here, so I've outlined the prostate in red, and then we would also be identifying some of the nearby organs at risk, such as the rectum behind it in brown, and then also on other slices we would see the bladder, and also be identifying the some of the femur bones. So the goal here would really just be once we finish contouring, then we work with other team members, including our dosimetrists and planners, to develop a radiation plan, which is kind of customized to the shape and size of the pelvis and the prostate and nearby organs. And so right now, all of our radiation planning is done on really done on CT simulation or a CT scan, and MRI is much better at visualizing the soft tissue. So the pictures here, picture A is the CT scan, and then B and C are different sequences of MRI. And in this study here, they had compared different physicians contouring the prostate, and in this study they had shown that when you're using an MRI, because it does have superior soft tissue imaging, your contouring is much more accurate. Usually the volumes are smaller, which can mean less side effects if you're having to treat less area. And then also there's less variability between physicians when you're using the MRI compared to CT. So really overall the MRI is just a much better imaging tool. And so certainly right now we're actually ordering a lot more MRIs for patients with prostate cancer, and we do have the ability during the planning process to, if we needed to kind of fuse or combine the CT simulation scan with the MRI, so that we can get more detail of the prostate to help in the treatment planning. One of the other advantages of an MRI is that we're now starting to be able to see more detail within the prostate. So for example, this is the same patient here, and one slice of the MRI on the left side, and then you can see the CT on the right side. And the CT scan, the prostate, when you look at the prostate on the CT scan, it really all just mostly looks the same. It's all this kind of homogeneous kind of tissue. You can't really get a lot of detail about the prostate, more detail within the prostate. Whereas with the MRI, there's a lot more detail. You can see there the arrow is pointing to an area of the prostate where there is more high-grade disease. And so, moving forward, there may be some opportunity, and there is a lot of research ongoing now about trying to target these areas where there is a more high-grade cancer within the prostate. We would target those areas with a higher dose, for example. And so there's a lot of research ongoing into strategies like that to try to improve the cancer control while not causing a lot more side effects. What I've been talking about up till now is really being on the planning or the simulation side of things. But the other part of the equation is the treatment delivery. So you can imagine that once we develop a radiation plan, we have this nice looking plan which will deliver a hot dose of radiation to the prostate. We need a way to deliver that in the patient every day on a consistent basis, and we want it to be accurate. And so there is a need for imaging on the linear accelerator so that we can match up our treatment plan with being able to deliver that plan in an accurate fashion. And in the past, this would be done, way in the past, say maybe 20 or 30 years ago, this might be done with an X-ray where one might align the patient's bony anatomy, based on the X-ray, and then you would treat that way. And with more advances in technology, currently we're now doing something called a cone beam CT, which is really like it's a little bit of a lower quality kind of a CT scan, But this is something that can be done on the treatment machine, the linear accelerator, and then we can align the patient and make sure that the anatomy of the treatment the anatomy of the patient on the day of treatment matches what we had planned out for them using the CT simulation scan. And so, but you can see there that the cone beam CT, we get better definition of the anatomy. We can see some of the prostate there. We can see the rectum. We can see some of the bones, but the detail is really not that great. And this is compared with the upcoming MR linear accelerator, where we can generate an MRI every day to help to line the patient up, and we can just see the tissues much better. And so that's really one of the main advantages of the MR linear accelerator, is being able to do an MRI every day to help with the accurate localization, so you make sure that we're delivering the treatment that we had planned in a more accurate fashion every day. One other thing that I also wanted to touch on is that the way that we deliver radiation is much more advanced now as well. So those top three pictures, this is kind of an alphabet soup of different radiation planning techniques, but the 3D CRT, that stands for 3D conformal radiation therapy. So that's the, I'll say, a little bit older way of delivering radiation. And you can see there what's outlined is so the prostate and some of the seminal vesicles, but the planning was not, not very conformal, meaning the higher dose is shown in the red there. It's really just like almost like a box. It doesn't follow the shape of the prostate very well. And so there's a little bit more tissue around the prostate which is being treated, which can lead to more side effects. The picture to the right, the IMRT, or intensity modulated radiotherapy, that's more conformal, and so you can start to see, there's not less of a box shape. There's some, curving of the higher dose to kind of better follow the contour of the prostate. And then the other picture on the right, VMAT, which is the volumetric modulated arc therapy, is also very conformal, where again you can see the higher dose kind of following the prostate. So currently what we're doing now is the VMAT technique, so a much more conformal treatment, meaning that the dose is really much tighter to the prostate, much tighter to where we want to deliver it, with a lower dose to the tissues around it. This has come about in the last 5 or 10 years with advances in the radiation delivery, but when you get a kind of a more conformal plan like this, you really need to be able to make sure that the treatment every day you have the patient lined up properly. Otherwise, you can imagine that if things are just a little bit off, then your treatment plan will be off, and you're not going to be delivering the dose to where you want it to. Because as you may be aware, radiotherapy treatment for prostate cancer still our most typical kind of treatment course is still with 20 fractions or 20 treatments of radiation. And so you really want to be able to hit your target every single day for all of those 20 treatments. And that's what the imaging on the delivery machines, imaging on the linear accelerators, that's what that's meant to do. And so this is kind of more just following the same point, that with being able to have more conformal radiation treatments, we have been able to increase the dose which you can deliver to the prostate with a comparable kind of side effects. And so there have been a lot of large studies now showing that an increase in the dose using these more advanced techniques has resulted in better cancer control with comparable kinds of side effects. So those have been kind of major developments in the last, that was kind of in the 2000s. And then I'll turn it over here to Dr. Lee.
So my name is Sangjune Lee. I'm a radiation oncologist at the University of Calgary. And it's thank you very much for the invitation to speak today. we're very excited about our LIDAC program coming to Calgary, and it's we're very happy to be able to present the developments to the prostate group. So back in the mid 2000s, we showed that higher doses of radiotherapy is more effective than lower doses. And so our standard dose for many years was 78 gray given over 39 fractions or treatments over 8 weeks, 2 gray per day. And then more recently, we've shown that 60 gray in 20 fractions, so treatment over 4 weeks by giving 3 gray per day is just as effective. So this effort to reduce the number of fractions was mainly motivated by the efforts to improve patient convenience and to reduce healthcare costs. And we use a term called hypofractionation to describe treatments with fewer fractions or fewer treatments with larger doses per treatment. In addition to convenience for the patients and to reduce healthcare costs, there is a biological basis for hypofractionation, reducing the number of treatments. If we look at cancers, different types of cancers, they have different responses to radiotherapy. We have a biological characteristic of each cancer called the alpha-beta ratio. And for head and neck cancer, for example, this alpha-beta ratio is 10 gray. And so if we were to give 78 gray and 39 fractions to a head and neck cancer, the biological equivalent dose would be 94 gray total. If we were to reduce the number of fractions and give larger doses per fraction, for example, 36 gray in 5 fractions, the dose to the tumor would, the biological equivalent dose to the tumor would go down to 63. However, if we look at prostate cancer, which has a biological characteristics of the alpha-beta ratio of 1.5 gray, 78 gray and 39 fractions would be 182 gray equivalent dose. When we reduce the number of fractions to 36 gray and 5 fractions, we actually get a higher biologically equivalent dose, so 211 gray. So this is relative to the other organs nearby the prostate. And so the dose to the prostate would go up, whereas the relative dose to the bladder and the rectum would go down, thereby increasing our probability of killing the tumor while sparing the surrounding organs. And so with the fractionation from 20 going down to 5 to 7, we would term treatments with 5 to 7 fractions as ultra hypofractionation. And studies have shown that conventional fractionation, ultra hypofractionation is equivalent to conventional fractionation in terms of cancer control. And so with ultra hypofractionation, the rates of toxicities have also been shown to be fairly equivalent with conventional fractionation, at least in this in a couple of studies. So on this, so this graph here shows the patient-reported urinary side effects. So at baseline, the urinary symptoms are 2 out of 10 in severity. During right at the end of radiation treatment, the severity of urinary side effects goes up to 4 out of 10, and then it tapers off. But basically, the red line represents the ultra hypofractionation, whereas the blue line represents the older conventional fractionation. The bowel toxicity might be a little bit higher for ultra hypofractionation, but as time goes on, the side effect profiles are basically equivalent. Other studies have shown that the ultra hypofractionated radiation schedules do result in slightly higher toxicity rates, and this may be due to differences in the radiation technique and delivery. And so the issue with the treatment of prostate cancer is that the prostate is sandwiched right between the bladder and the rectum. So the bladder in yellow and the rectum in brown. When a patient comes for radiation planning, we get a CT scan, and we base our radiation beam arrangement on this CT scan.
Now, patients, anatomies change each day. And if the patient were to come and had a CT scan every day during their radiation treatment, the bladder volume and the rectum volume would change. So here in the white outline, you can see the bladder outline, bladder volume changes quite a lot each day, as well as the rectum. And so even though we're trying to avoid the bladder when it's shaped like this, when a patient comes for treatment, the bladder might be in a different position. And so this is our conventional workflow that Dr. Quon had gone over. But to reiterate, basically, patients come for a CT simulation, they're planning scan, and we get this nice looking CT scan. Based on this scan, we plan the radiation beams. One way I describe it to patients is radiation treatment is basically kind of like focusing the rays of the sun with a magnifying glass. We want to magnify them, the beams from multiple different directions and focus on the prostate. And then for each treatment of radiation, either 5 to 39 treatments, patients come and they get a cone beam CT on the radiation delivery device. So this is a linear accelerator where we deliver the radiation treatment, and this part of the machine has a cone beam CT panel. And with these parts of the linear accelerator, we're able to get these low resolution images. But as you can see, this cone beam CT has much poorer resolution compared to the CT scan. And so this CT scan is mainly used to align the patient based on their bony anatomy. So you can see the bones decently, but we're not able to really see the bladder or the rectum very clearly. Now, in Calgary, we'll be getting the
MRI, and so basically, instead of the cone beam CT fused with the linear accelerator, we have an MRI unit that's of diagnostic quality fused with the linear accelerator. And so the workflow will change with the MR-Linac or the MR-guided linear accelerator. So when a patient comes, in addition to getting the CT scan, they'll also be getting a MRI scan. And on the MRI scan, we'll have much more detail about the anatomy. And patient will come will get their radiation plan done.
They'll come onto the radiation unit and they'll get an MRI each day. That's with diagnostic quality instead of the cone beam CT. And based on the position of the prostate in relation to the rectum and the bladder, we will be able to adapt the plan. So the bladder and the rectum will be re-identified, and the beams will be rearranged based on the daily anatomy. And so with this process, we'll be able to deliver much more focused radiation to the prostate while avoiding the bladder and the rectum. And so you might ask, how much does the bladder and the rectum move every day? With MR imaging, we'll be able to monitor the motion of the prostate in relation to the bladder and the rectum during the radiation treatment. And so in this image, we have the MRI scan going through a slice through the body sagittally. So here we have the spine, we have the intestines, and here's the rectum. This dark outline represents the position of the prostate when we do the initial imaging and planning. The thin outline represents the position of the prostate real time. And so, when the prostate is in the initial position, we can deliver the radiation beams. But as soon as we see a large volume of gas go into the rectum and displace the prostate, we can turn off the beams automatically and thereby spare the front part of the rectum. In addition to daily adaptation of the plan, I see that there's a question, Warren.
I understand that there is a medical substance that can be injected between the prostate and the rectum to reduce damage to the rectum, especially during salvage radiation. Do you people use that in Calgary?
Yeah, maybe I could just speak to that. That's right. It's a gel, excuse me, It's called the Space OAR or Spacer. So it's kind of a gel that can be injected between the prostate and the rectum, and it on average gives about a centimeter or so of additional space between the prostate and the rectum. So when you're trying to treat the prostate with more distance between the prostate and rectum, there's a much lower dose to the rectum. We're just in the process of opening up a clinical trial where we would be using something like that. But right now we're not doing the space OAR. There kind of are some select patients where it would really benefit. For example, some patients with inflammatory bowel disease where they're at much higher risk for complications related to the rectum. So in those kind of situations, if we really want to get it done, they have done some of these in Edmonton. So we have referred a few patients up there, but we hope to be doing some of our own space OAR injections here. Hopefully within the next year or so.
Okay, sounds like a good plan to avoid damage to the rectum, because that's worse than the cancer.
Definitely, we want to avoid those kind of rectal complications. They can definitely be problematic if you get a severe one, for sure.
So in addition to gating, radiation gating, so making sure that the prostate doesn't move too much during the radiation treatment, and daily adaptations, so adjusting the radiation plan according to the positions of the rectum and the bladder. Some of the other interesting applications of the MR-Linac include personalization of the radiation treatment based on biologic features of the tumor. And so in this slide, we have an example from pancreatic cancer. And with MRI, we're able to get some more information about the tumor. We're able to get information about the tumor vascularity, so how dense the blood vessels are. We're also able to get information about how dense the cells are within the tumor. And so with these special imaging techniques on MRI, we can track changes such as cellularity or vascularity. And now currently with our radiation treatments, we have basically a set treatment for all patients. So all patients, for example, with low to intermediate risk prostate cancer would come for 4 weeks treatment. But by looking at the biology, we can set a specific threshold. So we might be able to say that once we start to detect a certain level of vascularity or a certain level of cellularity, we can stop the radiation treatment. So one patient might be able to get through radiation treatment within 15 treatments, whereas another patient, depending on their biology, they might have to come for 25 treatments. And so we're able to identify patients that are responding to radiation treatment or not, and adjust their treatment accordingly. With the increased contrast and resolution with the MRI images, we're also able to do more precise targeting of the radiotherapy. So on the left panel here, we have a regular CT scan that we use for our radiation planning. On the right, we have the MRI scan. The prostate is what we target, and that's outlined in this blue line. And the dominant lesion within the prostate is outlined with this red outline. So there's a thought that the dominant lesion might be a little bit more aggressive and might require more radiation compared to the rest of the prostate. And so with MR guidance, we might be able to deliver an extra dose to the largest lesion within the prostate. In addition, we might be able to spare certain organs, certain parts of the organs around the prostate. So in order to maintain sexual function, we might be able to spare structures such as the blood vessels that go to the penis, as well as nerves that innervate the penis. And so by avoiding these structures, we may be able to better maintain sexual function for our patients. If a patient fails local therapy, or if they present with metastatic disease, if the PSA starts to rise, we now have technologies that are better able to identify metastatic lesions throughout the body. So
on this image here, we have a CT scan of the abdomen, and this is the liver. But with imaging techniques such as a prostate-specific membrane antigen targeted PET imaging, we're able to very easily identify a metastatic lesion within the liver. So identifying the metastatic lesions within the body have become much easier with special nuclear imaging tracers. But treating these lesions are still very tricky. But with the MR Linac, we will be able to treat these metastatic lesions with much more safety and confidence. So in this panel here, we have a metastatic lesion within the liver, the bottom of the liver. So this is the liver here, and then this is the metastatic lesion that we're targeting. And then right next to the liver, we have a loop of large bowel that's right next to it. And so this is our ideal plan. But when the patient comes for their treatment, they might have had a different, they might have had something new to eat, or just out of chance, the position of the large bowel may move. And so if we deliver that original plan, there's a high likelihood that the large bowel will be damaged. But because we're able to see the motion of the large bowel, we're able to adapt the plan on the fly. So here we have the radiation isodose lines. So the red lines represent higher areas of higher dose, whereas the green lines represent lower dose. And you can see that we can nicely carve out the dose and avoid the large bowel. And so here, the original predicted dose to the large bowel would be 27 gray, which would be quite dangerous. But with the adapted plan, we can deliver a safe 18 gray. The new cancer center is being built in Calgary. And a few months ago, we had the components for the MR Linac delivered to the new cancer center. And the cancer center is scheduled to open in 2023. And we hope to have this the MR Linac clinical program operational by then. There are several challenges in implementing a clinical MR Linac program. First is the limited availability. So in Calgary, we'll be very lucky to have 2 linear MR Linacs. Currently in Canada, there are only 2 other hospitals within MR Linac. And so I think Albertans are quite lucky to have this. This technology is very limited across Canada. Radiation treatments with the MR Linac are much more time consuming. So currently, with our current treatments, the treatments should be around 20 to 30 minutes each day. But with the MR Linac, because we have to do a new MRI each day and then adapt the plan according to the position of the organs, the whole treatment process might be much longer, from around 45 minutes to around an hour a day. And this could be quite difficult for patients to lie still on the machine for such a long time. However, there are possible solutions for speeding up the treatment. This includes applications of artificial intelligence. So the computer can help us automatically delineate the tumor and organs at risk, so the bladder and the rectum, and help speed up the process overall. In order to demonstrate that the MR Linac treatments are superior to our current treatments, we need to collect a lot of data from each individual patient and from many patients. And so, so our plan is for our center in Calgary to collaborate with multiple institutions with MR Linacs around the globe, and to pool all of the data together so that we have the statistical power to demonstrate improved outcomes. In order to accomplish this, we do need your support. Basically, research is what drives advances in cancer treatment. And so if you put in the research, we hope to find the cure hidden behind here. Currently, we have the own cancer fundraising campaign that's going on, and our goal is to raise $250 million, and currently we're at $80 million. And so we kindly ask for you to consider making a donation. And in our MR-Linac program, the MR-Linac program is heavily reliant on medical physicists. We're dealing with very high-tech machines with lots of basically photons and magnetic fields, and so we need very strong physicists to support this program. And so if you're able to make a donation and direct it towards the MR-Linac program and our physicists, that would be much appreciated. And so with that, I'd like to open up to questions.
Warren had another question on PSMA. When it detects a lesion, how is it treated?
Yeah, so every patient is different, and so we'll have to consider the whole clinical context. So just to give a little bit of background, previously cancer patients were categorized as having localized disease versus metastatic disease, but now we're understanding that there's a little bit more the nuance or spectrum of metastatic disease. So a patient with one metastatic lesion has a better prognosis than a patient with 10 or 20 metastatic lesions. And there's building evidence that ablating or totally destroying the metastatic lesions in patients who have limited number of metastatic lesions can help prolong patients' lives. And so this can be accomplished through surgery or through radiation or other methods, through interventional radiology, radiofrequency ablation. There are many different types of treatments to destroy metastatic lesions. And we believe that the MR-Linac would be a strong tool within that armamentarium, or the range of options. And basically, patients would go through the whole same process. They'd get a CT scan, an MRI, they have the plan created, and then radiation delivered over 1 to 5 treatments in a very focused manner.
Dr. Lee, this is Warren speaking. It's my understanding that radiation oncologists will not treat more than 5 located areas of so-called hotspots. Is that in fact true?
So this is an area of continued research and development. And so, yeah, currently, we do have trials open where patients are randomized between lower dose palliative radiotherapy or standard of care therapy versus high dose radiotherapy to try to get rid of these metastatic lesions. There is no clear cutoff of where to distinguish patients with localized metastatic disease or limited metastatic disease versus widespread metastatic disease. But currently, in general, we have that cutoff at around 3 to 5 metastatic lesions.
Okay, at what level would a PSA reading have to be before the PSMA scan would actually show all the lesions that could be treated?
I'll defer this question to Dr. Quon.
Yeah, it's an interesting question. I mean, the PSMA PET scan is, it's kind of a newer scan. One we don't have in Calgary yet, because you actually need you need a cyclotron to create these radioactive isotopes, and that's something that we don't have. There's some talks undergoing to try and build one, but with regards to your question, the PSMA PET scan is a very sensitive test, so it's a much better, or I would say much more sensitive test compared to our standard type of imaging, such as a CT scan or a bone scan. Those are the types of scans that we're currently doing to look for any metastatic disease from prostate cancer. So PSMA PET scans, they can actually detect metastases with quite low PSAs, like even say at the 0.5 to 1 level even, which is quite low. So and it's not like a specific cutoff. Just the idea is that the higher the PSA, the greater the chance you would probably pick up some lesions, but there isn't like a specific number where, under that you don't detect anything, and then, over that you might kind of detect all sorts of disease. So it's really more of a I would say kind of like a trend that the higher the PSA, the greater the likelihood there may be spread of the cancer, and you're more likely to find lesions, but it can detect it at very low PSAs for sure.
I see Richard has a question, or his hand is raised.
Yes.
Just unmute yourself. Yep.
Yep. Thank you, Brad. I had my radical prostate surgery over 11 years ago, and I must say successfully. But am I getting the impression from the doctors tonight that with the advances in MRI technology, that surgeons will be doing fewer and fewer radical surgeries?
It's like a lot of these advancements in the radiation kind of planning and delivery will certainly help to kind of improve outcomes from radiation treatment. I think that there's still a lot to kind of learn in terms of who best might benefit from a lot of these technologies and so on. I don't think that radical prostatectomies are going to be going anywhere anytime soon. They're still, it's still a very good treatment for prostate cancer. So, I don't think it's something that, the treatment will be completely all radiation based, or, I'm not anticipating something like that. But I think we can definitely improve on our own outcomes from patients who are treated with radiation.
Thank you, Dr. Quon. Thank you.
Yeah.
Okay, Ron, Ron Singer, you have a question?
Yeah, two questions. First, for people of a certain generation, I'll call it the Gordon Sinclair question. The integrated MRI Linac versus the CAT scan and linear accelerator today. What's the difference in cost to treat a, quote, if there's a standard prostate cancer patient?
So I believe a very modern regular linear accelerator would cost around $1 million. An MR Linac would cost around $2 million. And so just the machine itself is quite a bit more expensive. In terms of the staffing, there are more members of the hospital who need to work on the MR Linac. So probably around 3 to 4 versus two staff members on a regular machine. And then currently the MR Linac treatments are much longer, around double the time. So if you add all these things up, it is quite a bit more expensive, but we would hope to show improved clinical outcomes that would offset or even show that the MR Linac would be more cost effective to the overall population.
So you would figure that in the long term that it would be accessible to quote unquote all prostate cancer patients who opted for radiation treatment?
I think it will take a while for this type of technology to be available to anyone who wants it. This will only be available to patients in southern Alberta in the short term. In the longer term, it would depend on how many more of these units will be available in other locations.
And the one supplementary question, you mentioned that there are 2 other of their MRI Linacs in Canada. Where are they located, and how long have they been in operation?
So they are both in Toronto, one at Princess Margaret, one at Sunnybrook. And I think Sunnybrook has been operational the longest, maybe around 2 to 3 years.
Thank you very much. Those are all my questions.
And I would assume your research would be working towards showing the benefit in the long term outcomes for patients. So valuable research for sure. We've got a couple of other questions. One quick one on chat, will Calgary have a cyclotron when it opens in 2023?
No, the cyclotron discussion is kind of separate from the cancer center. I don't like. I believe I think there's been some talks about cyclotrons for kind of on and off for a number of years now. I'm not actually part of those discussions, so I don't know where that's at now. But I have heard that there are some more discussions about it, but I don't really know a lot more details other than that, unfortunately. But it's kind of a separate. It's separate from the new cancer center, as far as I understand.
Good, thank you for that. Now, John, you had a question. I'll just ask you to unmute. Yep, you're good.
Hi, my name's Lori. I'm John's wife. So my question is for Dr. Lee, and thank you very much for your presentation. You mentioned that you could theoretically, you could target the dominant tumor. You're talking about tumor density and vascularity and protect nearby vulnerable structures like the nerves and blood vessels. So my question to you is this theoretical, or do you know in fact that you are able to do that? Yes, that's exactly my question.
Yeah. So these are areas of research right now. There are clinical trials that are testing out this idea right now.
All right. Okay. Thank you. And then my other question is, will a physician be operating this machine when you start using it and when you get it and have it operational?
Yeah, so we will have a very large team, including radiation therapists, physicists, radiologists who will be participating in this type of treatments. But yeah, the radiation oncologist will take more of a leadership role and will be supervising this whole treatment process.
Very exciting. Thank you very much.
Okay, I see, Warren, you have one more question.
Yes, I do. I don't want to step ahead of anybody else, but I just wanted to ask the doctors, using a PSMA scan is going to show up all kinds of tumors, maybe in soft tissue, maybe on your bone or in some other place. When I listened to a webinar from Vancouver, they're using the PSMA lutetium radioactive tracer to kill all of those tumors and apparently having quite successful. Can you comment on the lutetium treatment? And if somebody is facing metastatic prostate cancer, is it possible to get a referral to the Vancouver area to get the lutetium treatments?
Yeah, so for those that may not know about the lutetium treatment, so we were talking about the PSMA PET scan, which is being a more sensitive test to find metastatic prostate cancer. So the lutetium is essentially kind of tagging a radioactive molecule to the PSMA so that the PSMA will go and basically find the prostate cancer, and then the radioactive kind of molecule would then treat the metastases. So I mean, this is it's a very new treatment. I don't, if I mean, it would certainly be possible to refer, I suppose, to Vancouver if they're doing it there. I don't know much about their program there, if they're just doing it on clinical trial or not, but that would be something that we could certainly look at doing if if a patient had a lot of PSMA kind of avid lesions. I think there's still a lot of research to be done in this area, depending on how many spots that might be found with a PSMA PET scan. As you heard Dr. Lee talking about, if there's a limited number, 3 or 5, then we can certainly treat that with external beam radiation, like the stereotactic body radiotherapy kind of techniques. So that's delivering like a high dose of radiation to those areas. So that would be another way to treat some of those spots. And then if there are numerous ones, in excess of the, say, 5 treatments, then we'd also have to at least consider whether doing drug therapies would be another option. So it really depends on the kind of specific situation. But if the patient was interested to discuss that more with the lutetium kind of program there in Vancouver, then we could definitely refer you and explore that option.
Yeah, getting back to the lutetium treatment and the PSMA test, just for the sake of interest, I do understand that the Mayo Clinic has advised me that Germany and Australia offer it as a optional standard treatment for people that are facing rather advanced cancer. And apparently it will become standard treatment in the US within the next year. Thank you.
Yeah. Yeah, I'm aware of a gentleman in the US that feels that FDA approval is going to be forthcoming for lutetium. He's in a clinical trial right now. So this year, we hope. On that note, no other incoming questions. I just want to thank Dr. Lee and Dr. Quon. I'm very excited to see the progress that's being made and how quickly the new cancer center is coming along. It's hard to believe that we can now say next year that it'll be opening, and it'll be such a great benefit for the city and certainly our members. So I want to thank you personally for sharing your time with us tonight, your knowledge and your experience. Again, I'm just overwhelmed by the knowledge base that we have available to us, and the work that you're doing is outstanding. So we thank you for that, and certainly for sharing your time with us tonight. It's so greatly appreciated.
Well, thank you very much for having us here today.
And I love that picture behind you now. I can hardly wait to get to go inside and see all the great work. So it's very exciting.
Yeah, we're very excited. Thank you again.
Good.